Current drug technologies, in the below-the-knee sector, illustrated with various clinical cases. The proposed algorithm for treating this sector begins with an arteriography. The first step in treating these lesions, whether stenotic or occlusive, is performing a simple angioplasty for 3 minutes. We then reassess the vessel's condition with a follow-up arteriography, where we may encounter 2 scenarios. If the outcome is optimal, we conclude the procedure. If not optimal due to recoil, residual stenosis greater than 30%, or flow-limiting dissections, a drug-eluted stent may be placed. In the latter case, we consider whether the patient has previously undergone revascularization in the same segment. If it is untreated, we proceed with a second simple 5 to 7 minutes angioplasty, followed by a reassessment. If already treated, proximal BTK sector lesions, only one outflow vessel, or if there are extensive ulcerated lesions in the lower limbs, we opt for a second-line treatment using a drug-eluting balloon. Here we present the case of an 86-year-old patient, a former smoker with the typical pathological history of vascular disease patients. He presented with grade 5 Rutherford obliterative arteriopathy in the right lower limb, with necrotic lesions on the foot, and an ultrasound showing a patent femoral popliteal sector without significant lesions. In this case, the diagnostic arteriography revealed a complete obliteration of the anterior tibial, posterior tibial, and proximal peroneal arteries, along with critical stenosis in the tibio-peroneal trunk. Thus, after an initial 3-minute angioplasty that did not result with an optimal result, we proceeded with targeted treatment using a drug-eluting balloon and stent. In this case, through transcollateral recanalization, we were able to perform a drug-coated angioplasty of the anterior tibial artery, peroneal artery, and tibio-peroneal trunk, as well as stenting of the TP trunk and peroneal arteries. In this arteriography performed 19 months after the intervention, we see that the BTK sector remains patent with good flow dynamics. The second case involves a 68-year-old patient, also a former smoker with the typical pathological history of vascular disease patients. He presented with grade 5 Rutherford obliterative arteriopathy in the right lower limb, with significant ulcerated lesions on the leg, with an ultrasound showing pathology in distal trunks. The diagnostic arteriography revealed proximal TP trunk stenosis with distal occlusion, as well as occlusion in the middle third of the peroneal artery and the proximal and middle thirds of the posterior tibial artery. Thus, after an initial 3-minute angioplasty, the image obtained consisted of recoil. We proceeded with targeted treatment using a drug-eluting stent. The lesions were recanalized anterogradely, and 2 overlapping create stents were implanted in the tibio-peroneal trunk and the proximal tibial segment. The following image shows the significant improvement the patient experienced after 9 months. We also observed the stent's patency 6 years after the intervention. The final case is about a 72-year-old patient with the same characteristics as the previous patients, with grade 5 Rutherford obliterative arteriopathy in the right lower limb and an ultrasound showing occlusion in the proximal anterior tibial artery. In this case, the diagnostic arteriography revealed an occlusion on the anterior tibial artery, with only one outflow vessel. Thus, after an initial 3-minute angioplasty, we observed a dissection in the proximal part of the anterior tibialis, so we decided to proceed with a drug-eluted stent. 9 months after the stent placement, good patency of the artery was observed. Thank you for your attention.